So this is the Intro to Healthcare Careers event, and this came about with a partnership with Unity Point Health at McFarland Clinic. We started this program 2 years ago, and the reason behind it was because McFarland Clinic could not offer high school job shadows. So this is a way that McFarland Clinic can show students what they do inside the clinic without breaking any confidentiality laws like HIPAA. This year, we are proud to say that Iowa Veterans Home and Primary Health have also joined in this Intro to Healthcare Careers Day. And so we have 4 partners, which is wonderful to be able to show students a wide variety of careers in healthcare and take them through all the facilities and have hands-on activities that they can do in hopes that they see that healthcare is really something that they want to do, or maybe they rule it out altogether and decide healthcare is not the right field for me. And so they're making those decisions earlier on.
Some of the activities that the students will get to participate in today are during the morning session, they got their choice of participating in hands-on activities in the Iowa Valley Sim Lab or participating in activities at Unity Point Health. They will also get a tour of the vet's home, and they will do a pharmacy simulation as well as blood pressure checks. And then in the afternoon breakout sessions, they will have the opportunity to do some more hands-on activities like insulin injections, triage, splinting, use the AED machines in first aid and CPR. And this will give them more hands-on experience to make a more educated decision on if they want to pursue a career in healthcare.
We are so excited that you are all here today to learn about all the different areas of healthcare careers. We have a wonderful day planned for you. We're going to start out with our panelists and just kind of to go over a few reminders for today. Thank you to those of you who completed the online self-HIPAA study. I greatly appreciate it. I'm still getting some this morning. Just a reminder about HIPAA. HIPAA protects our information, our personal health information. Therefore, we ask that during this whole day that you keep your cell phones turned off and in your pockets. Because we don't want you shooting pictures or Snapchats and then having somebody's picture in the background that doesn't want their picture taken, or in case you snap a photo in somebody's pill bottle, that would be a breach of HIPAA. So we ask that during our entire sessions that you keep your cell phone in your pocket. The only time that you should be allowed to take that out is during our bus trips, okay? Even at lunch, we're going to be at the Iowa Veterans Home. We ask that you do not take your phone out because we don't know if you're taking pictures or not, okay? Also, a reminder that if you do see people you know at the Veterans Home or at Unity Point when we are walking around, you cannot go back and disclose to family or friends that you saw Uncle Dan in the hospital today. That, again, would be a breach of HIPAA. So we have to make sure, a lot of you have heard me say this before, different HIPAA trainings. What you see today needs to stay in those 4 walls. You can go back and tell your parents or friends, yes, I went on this Intro to Healthcare Day. It was super neat. We got to meet with a lot of nurses and go around the Veterans Home and talk with residents without giving away any puzzle pieces, so to speak.
Good morning. How are you guys today? Good. I'm Shelley Jakey. I'm the Marketing and Public Relations Director for McFarland Clinic. I grew up in LeGrand, Iowa, just east of here. Live west of here on a farm, but my office is in Ames. I'm in communications. Today you're going to meet a lot of folks in the healthcare profession, many of them clinical, and some people that are non-clinical, such as myself. So you'll learn about a lot of different roles in healthcare. I'm going to introduce our panelists this morning. They've got a lot to share with us, but before I do that, I want to ask you a question. Can I get you warmed up here thinking about questions? What are your hopes for today? What do you hope to get out of today? I know I spoke with 2 young ladies over there. You want to share some of your thoughts? What did you hope to learn today?
I hope to see a surgery and learn about all the different types of careers. So when I go into the medical field, I have an open mind of what I can be.
Okay, great. And you're going to get to see a surgery here. Well, anyone else? What did you hope for today? Hopefully more than maybe having donuts and fruit. We see some other things, okay? Well, as we're visiting with the panelists, and you're going to see some videos, a day in the life of each of these panelists and these professionals, I want you to be thinking about questions that you have. This is your time, okay? Don't be shy, and no question is a silly question. They're all very important questions, okay? So let me introduce to you our panelists here this morning. First, we have Dr. Eric Close. He's an orthopedic surgeon with McFarland Clinic. Dr. Close joined us in August of this year, moved here to the Marshalltown community. And we have Callie Williams, who's a pediatric nurse practitioner at Unity Point Hospital here in Marshalltown. And Dr. Lance Van Gundy, emergency room physician, and actually is from Marshalltown community as well. Grew up here in this area and is a practicing physician. So I'm going to start with an opening question for Dr. Close, and then we're going to take a real quick look at a day in the life of Dr. Close. So Dr. Close, I'm going to open up with what inspired you to go into medicine, to become a physician?
I went into engineering originally and thought it was the right choice for me. Loved learning about engineering, and then when I got out and did it, practice as an engineer, it just was not very fulfilling for me, so I wanted to get back in, and I had a couple of sports injuries. I tore my ACL a couple times, and then I liked how I was treated, and I liked working with that physician, and I said, this is what I want to do.
Let's take a day in the life of you, and then we'll open it up for some additional questions that we have.
I originally went to college for mechanical engineering, and I enjoyed it while I was learning about it. And then when I got out in the practice of engineering, I found out it was a little bit too much in front of the computer for me. There wasn't enough hands-on, and I'm a little bit of a people person, so I like interacting with people. And so I started pursuing other interests. Originally, I was kind of thinking about medicine, and then that kind of steered me towards that, was that I could interact with people and still have some academic challenges to it. The most rewarding part of being an orthopedic surgeon is finding or identifying a problem that's causing a patient pain and being able to treat that problem and having the patient get better. The challenges are when you can't always identify what that problem is or what might be causing their knee pain and their shoulder pain, and there's just sometimes you can't help the patient, you can't figure it out, or you go down different paths and sometimes it takes a couple months to figure it out, and those are the patients that need you the most. Around on patients, if I have any in the hospital, it can be 1 to 3 patients if they've had surgeries or maybe they came in as a consult and they were staying in the hospital. So I'll round on them pretty early, and then my office starts at 7 a.m. When I have office days, and surgery start at 7:30. And so I'll either see patients in the office or I'll do a few surgeries, and then once I wrap up, sometimes my evening doesn't end if I'm on call, and I might have some ER consults during the night or even during the day. There's quite a bit of preparation that goes in, usually the couple weeks before the surgery. So patients I'm seeing in the office, for instance, of a total knee, I'm looking at their x-rays, talking to the patient and identifying any issues technically that I might need to identify and make sure I have certain instruments available for me. And if they don't, the product reps need to make sure that they bring that in if I think that surgery might not be straightforward, it might be a little more challenging. And then anything that I haven't done in a while, there's some procedures we don't do only a couple times a year, and so I might have to review my approach on how to get to that particular body part. I might also have to review certain techniques that we haven't done or alternatives, because during surgery, if you get stuck and something's not working, you don't want to not have an alternative way to fix it. In the operating room there's quite a large team. There's anesthesiologist, there's a scrub tech that's usually there to hand you instruments. There's a circulator nurse that's there to hand you sterilely different products. There's usually a first assist, someone that can help hold retractors or hold an arm or hold a leg in a certain position to make the surgery easier. And then there's usually a product rep that's available as well if we're putting in certain plates and screws or something like that. So the team is usually about 6 to 7 people. So there's 4 years of college, there's 4 years of medical school, and then 5 years of training. And then if you want to do a fellowship and be a specialist in orthopedics, usually it's another year or 2 on top of that. And you gotta work towards that even to get into med school. Usually you gotta start shadowing or get into like a EMT type job just to show commitment to medicine and make sure that it's the right fit, because you don't want to go through all that training and find out that you don't like it.
All right, so how many of you saw that surgery and said, yep, sign me up, I want to do that? All right, here we go, we got our recruits right here. Well, today is all about learning what you think you would like to do, or maybe what you know you would not like to do. Dr. Close, I want to ask you, what was that procedure that we saw?
That was part of a total knee arthroplasty, a patient with bad arthritis, and I was cutting off the backside of the patella for replacing with a piece of plastic, that part of it.
Okay, and then the gentleman that you were in the office, and we could see that there had been a surgical intervention there. What was that procedure?
He had broken his clavicle, playing some intramural sports, and it was pretty displaced, and I gave him the choice of a bump or a scar.
Okay. So the question was, what hardships have you faced as a surgeon? What have you done to overcome them?
For me, it was mostly perseverance. I had really good test scores and really good grades, but I didn't realize kind of there's the backside of medicine. They really want you, if for medical school, and I think this is true for nursing school, they want to know that you're committed to it. And I was just an engineer. I had not done any shadowing, and so it actually took me 4 years of applying to get into med school, which was a very frustrating process because all the metrics said that I should have gotten in, and I had good feedback, said I had good interviews, and it's just they were worried. The schools, the medical schools, were worried that I wouldn't stick it out. So my undergraduate was mechanical engineering. I had a college job doing satellite communications. So when I quit my engineering job, I got back into satellite communications because it was a 24-hour facility, so I was working graveyards so that I could pick up the prereqs that I needed to get back into medicine.
So what courses would you recommend for these students, either, well, let's say in high school, maybe things that they should be thinking about if they wanted to take a similar journey as you?
Math and sciences, primarily sciences, so for medical school you need chemistry, organic chemistry, physics. I think you still need physics. They might have changed that recently. Yeah, calculus. Those are all the prereqs. Anatomy is not required to get into medical school because they teach you anatomy, but usually if you take anatomy during your undergrad, it'll make medical school a little bit easier.
How many of you have ever been treated by an orthopedic surgeon at the occasion? Okay. So Dr. Close, I'm always curious, you've got to have a lot of confidence to go in there and cut into somebody's bone, and I mean, like, how do you do that?
The surgical residency is kind of that kind of a process. Surgical residency is 5 years. In your first year, you spend a lot of time just taking care of patients on the floor. You're not really allowed to operate all that much. And then they start you out just suturing in the OR. You don't really get to do a lot of the more technical aspects, and it's kind of a graduated, second year you do a little bit more, third year you do a little bit more, and so on. And so by the time you're doing your 5th year, you're kind of flying free a little bit.
Okay. I'm going to move on. Thank you, Dr. Close. Round of applause for Dr. Close. So good morning, Callie. Thank you for joining us. A pediatric nurse practitioner. Callie, why don't you share with the group what inspired you to go into medicine?
So when I was 7 years old, everyone asks you that question, like, what do you want to be when you grow up? So when I was 7, my sister was born in March, and she was quickly diagnosed with having some heart problems that weren't sustainable with life. So she went to Iowa City, University of Iowa Hospitals and Clinics, and so I spent a lot of time there, especially over that summer. And then she even had a heart transplant when she was 4 months old, and it didn't go well, and she ended up having to have a lot of interventions. She never left the hospital, and she passed away November 1st of that year. So she was alive 8 months. And I spent a lot of time in the hospital. My mom was there with her the whole time, so I didn't have a mom at home. And anyway, the nurses made a huge difference during that time for me as a child. They were very playful. I spent a lot of time just with them, and they always were helpful with, educating me on what was going on at my level. Anyway, I decided I wanted to go into nursing and to make a difference in pediatrics with kids and be an influence for them and take care of the patients and families. So then I got into nursing, and during nursing school, you kind of learn more about yourself as you get older, and I just wanted to have a bigger impact in the outcomes for the patients. And so I took the avenue of going to graduate school and got my doctorate to be a pediatric nurse practitioner. So now I can provide care as a provider, more at a provider level, and be more influential in the outcomes. So.
Okay. Let's take a look at a day in the life of Callie.
When I come to work, I don't always really feel like I'm coming to work. I feel like I'm coming to meet someone new and to be an important part of their life and taking care of them. You never really know what you're going to get involved in as far as caring for families and children and managing their health care. And you never really know what's going to walk in the door and what it's going to demand of you, whether that be mentally, physically, and we're all human. And I think the most challenging part of my role in healthcare is being equipped to do my job to the best potential I can and to adequately care for children. A typical day for me right now is a little bit different because I am a pediatric nurse practitioner, but I'm also practicing in a hospitalist role as well as a primary care provider in a clinic. So what that means is I see patients that are either born as newborn babies in the nursery here at the hospital, or pediatric patients that need to be admitted directly to the hospital from either a clinic setting or in the emergency department. So when I come in, I round on those patients that are already here in the hospital, and then I also make time during my day to see patients in the clinic setting. So I come in and I see the patients and talk with the family, examine them, make the plan of care for that patient for that day, and then I come over to the clinic where I am now and see patients here and take care of them. I work side by side with the patients and the families. For the most part, I work with the nursing staff in the hospital, and they're a huge part of these patients and getting the care that they need. The nurses are at the bedside with them and play a huge role in communicating with all departments and healthcare teams to take care of the patients. So the nursing staff is probably who I would identify as working side by side with. I'm also, being more in a provider role now, I'm also working side by side with more management, nurse managers, other providers, and developing policies. So I'm kind of doing both sides of that and working with a wide variety of healthcare professionals. There's so many roles in healthcare that you can be involved in, but at a provider role, I just would recommend, starting wherever your heart pulls you and kind of just going with it and committing to it. I set a goal to become a nurse, and from that I decided I wanted to be more in a provider role, and for that option was nurse practitioner for me, and I just stuck to it until I got here. And it was a lot of school and it took a lot of time, but I just kept enrolling in school and going to each semester and finishing my classes and just sticking with it.
Kelly, can you share about where you went to nursing school and then where you went to be able to get your nurse practitioner degree?
Okay. Well, my journey started at the University of Iowa, and I went there to do nursing and then found myself walking on the Iowa softball team and playing softball there for 4 years. So starting nursing school there was conflicting with if you're an athlete at a D1 school or any college. I mean, they require a lot of your time for practice and things. So I ended up doing a wellness coaching degree there, and so for that, my option was either to stay in Iowa City, or I heard a lot of great things about Grandview University in Des Moines. My sister-in-law now had gone there and had great things to say, so I kind of applied to a couple places and ended up going to Grandview University in Des Moines. Very vigorous program. They always just said trust the process, and I can tell now how things that we did in that program are so applicable to like graduate school and developing policies and things like that. Like I did that in undergrad, so that's crazy to me.
Was your undergrad for nursing then?
Yeah, so I got my Bachelor's of Arts at University of Iowa, and then I did Grandview and got my Bachelor of Science in Nursing, so BSN in nursing. And then from there, I took one semester to pass my nursing boards, get a job, and applied to grad school. So I took that semester off, and then started the graduate program at the University of Missouri in Columbia. It's an online program, and they provided, we would go there once a year and do a skills check-off and things like that. Otherwise, during my program, it's doctorate degree, so it was 5 years. And so during my classes and stuff, each class has clinical, and so I would be responsible to find my clinical placement. So I actually lived in Kansas for a little while during that time, so I did a lot of clinicals there. I did a lot of my clinicals with providers, physicians, because I felt I needed a mix of knowledge and experience, and then did clinicals in Des Moines and Link. So clinicals was a big part of graduate school in addition to developing policy and research. So it was a mix of that, practice and research. So.
What questions do you have of Callie, our pediatric nurse practitioner? Questions? You know, when we were putting this panel together based on feedback from the previous 2 years, we knew that students wanted to hear from somebody in the OR, kind of close to surgeon, somebody in OB and mother and baby care, and then somebody in ED, you know, emergency room, ER. So these are pretty significant areas. Any questions that come to mind? I've got a couple more for Callie. Okay, so how, when you're working with parents and children, I can imagine that there's times very stressful. How do you keep yourself, I guess, objective? Personally, I know I probably become emotionally invested, and maybe that happens when you're working with patients, but how do you keep yourself pretty objective about what's in front of you?
Just as far as like not letting other things distract me or influence me. Well, my role is very, like I said in the video, I get to see, I mean, I'm in an acute setting and then I'm in a primary care setting, and you may not understand the difference, but in the hospital, kids can be sick when they're newborns. They can be born and need some resuscitation or help transitioning to life. So that's a different thinking than when you're seeing somebody in clinic for just like a well child visit. So in the hospital setting, to remain objective, and that's where I need to be more objective and not listen to a lot of extra noises. Just focusing on what's in front of me. We've had a couple preterm babies delivered lately that required some resuscitation and even intubation and things like that. So you don't really have a lot of, when you get into this profession, you learn to be objective, I guess, and you know your examinations are mostly objective, and so I guess just it's important to be that way and to remain focused on what's in front of you and taking care of that situation. In a clinic setting, I really try to listen to the parents, and because they're really who's going to go home with that child and take care of them. So if you don't listen to their concerns, even if you don't think it's objective, you're not setting them up for success at home. So you really have to listen to what their concerns are. Maybe try to educate them if they really shouldn't be doing something. Otherwise, meeting them in the middle or supporting them in what they're doing. I knew that I wanted to work with children, and so I always tried to, in college I worked as a waitress and things like that, but once I started looking to go to Grandview for nursing school, I started looking for positions that I could take care of children. So I would, depending on, you don't have to be interested in pediatrics, but just in healthcare in general, if you can work as like a nurse assistant, or they can be called nurse aides or patient care techs, you can go through that class in like your senior year of high school and get that certification, and then you could work in healthcare that way. Otherwise, volunteering and other ways of getting in the healthcare field. I would suggest doing that, and then from there, you can decide if, you know, medicine and nursing are different, and you can decide kind of by maybe doing some job shadowing and things like that, as far as what direction you want to go as far as becoming a provider.
Any questions of Callie? No? We're going to visit. Thank you, Callie, very much. Round of applause for Callie. Dr. Lance Van Gundy joins us as emergency room physician here in Marshalltown at the Unity Point Hospital. Good morning. Good morning, Gundy. We also opened with the same question I asked your colleagues here. What inspired you as a Marshalltown High School graduate? What inspired you to go into medicine?
My journey to medicine was not very imaginative. I come from a family of people in medicine. So, for instance, if you saw your dad being a butcher every day, you'd think I could be a butcher. If you saw your mom, running a lawyer company, you'd probably think I could do that too. Because when you see it every day, it doesn't take very much imagination to think I could do that. My message with you with that is we're here to be your cheerleaders. I don't want you to think you have to have a family member to get into medicine. I just wasn't very imaginative to think about doing anything else. So for me, I saw a family member providing care to people in our family. I had my laceration on my toe sewn up on a Saturday morning before a MFL flag football game, and I just thought that was really cool. And I thought if I could do that for my own family, that would be really neat. So that was probably the indelible experience for me at about age 12, and I just always thought, I'll go into medicine since that's what people in my family do.
Let's take a look at a day in the life, a little bit of video from the emergency room.
I took an Uber on vacation last week, and we were talking to the driver. And he accidentally learned that I was a physician, and he told me he had one regret in life. He was basically retired, now was an Uber driver, and he'd been a certified public accountant for many years and very successful. But he said the one regret he had is that he felt like he never made a difference in somebody's life. And I was kind of thunderstruck by that because I feel like I make a difference in somebody's life every shift. Now, it may not be heroic. Maybe I'm just putting in some stitches on a 2-year-old's chin, or I may be setting a broken bone, or I may be comforting a psychiatric patient who's completely decompensating. But I get to do cool stuff too, like manage people when they've had a car accident, diagnose appendicitis, manage them with an acute heart attack, or a loved one who's having a stroke. Emergency medicine in particular struggles with managing people who are in crisis with behavioral health and psychiatric and substance abuse issues. It's not really why I got into medicine. I'm happy to be of service to those people, but they can be pretty challenging to take care of at times. So depending on which shift you're working, a typical day for me can be different. If you're working the night shift, you start at 8 o'clock at night, and you come in and you roll up your sleeves, and it's always really busy. There might be 8 to 12 people in the department waiting to be seen. And I'll introduce myself to the daytime physician, receive any patients that they need to pass off to me, and then you just start running. Your caseload is whatever comes in the door in emergency medicine. So if you're lucky, it's ankle sprains and head colds. If you're unlucky, it's car accidents, a few psychiatric patients, and somebody having a heart attack. You don't have to be a straight A student, but you really have to have your priorities straight, and then start getting involved. If you think that maybe medicine or some medical field is right for you, then volunteer or get into a nursing field or a paramedic field to kind of get some exposure to that. Volunteer in the hospital. Another great job is to work as a scribe. We're always looking for scribes in the emergency room where you basically record and document everything. And then you can start to see what is the flavor of the physician-patient interaction, and does that appeal to you? If you have a heart to make a difference in people's lives and be meaningful to them and help them out, then medicine could definitely be the field for you. We have a robust and active program for people who are serious about medicine where they can come shadow me or one of my partners in the ER, and I would really encourage you to do that. That might be another way to for you to look and see, is this something for me? If you can do some biology, some chemistry, and possibly some anatomy in high school, it's going to make the college prep work that much easier, because you have to have that stuff before you can sit for the medical college aptitude test or the MCAT. My other advice, though, would be well-rounded. Do lots of things. Med schools these days like to see people who are involved in other activities, who know how to have a life outside of the science classroom, maybe who also hold down a job, or who volunteer at a nursing home or on an ambulance service. I think you need to show that you're passionate about the patient experience and being involved with patients these days, and yet that you're also a well-rounded student who can juggle a lot of things at the same time, because then we know you're going to be able to manage the stress of medical school and finishing. It's hard for the medical schools to take a risk on somebody if they're not sure they're going to be able to manage the stress load. But if you demonstrate that you can stay out of trouble, get good grades, and still be involved with other things in life, then you're going to probably be an attractive applicant to a medical school.
Dr. Van Gundy, obviously your day is really unpredictable. You don't know what's going to walk in the door. How does medical school and your residency prepare you for all the variety of things that you have to diagnose and treat?
You'll have a mandatory set of rotations that take you through all the different fields, from different surgeries to different medical fields, pediatrics, OB, cancer wards, and that's twofold. Number one, it's teaching you a lot of things about those different patients, but also it gives you a chance as a student to say, is this what I want to do when I grow up? And then once you sort of pick the specialty that you're interested in, as Dr. Close referenced, you after you're done with medical school, you go on residency, which is another usually 3 to 5 year program, but that very much specializes in what you're doing. So for ER medicine, once you start an ER residency, you still do rotations in all of these fields. You'll have a pediatric rotation, an OB rotation, a trauma rotation, a surgery rotation, and then you'll repeat those. And of course, you're also getting rotations in ER. So you're sort of immersed just by nature of the training, over time, and you get some exposure to all these fields in that regard.
Without revealing any PHI, when was the last shift you just worked in the emergency room, and can you share maybe 3 or 4 different cases, things that you had to attend to?
I was just on 3 nights ago. We had a minor car accident. Everybody got to leave after that. We had a stroke patient that we gave a clotbuster medication to that we then transferred to Des Moines. We had an Iowa Veterans Home patient who got admitted for pneumonia. I was just telling Callie, I took care of a little kid with vomiting and diarrhea who was moderately dehydrated. We had to start an IV, give some fluids, and watch that kid for a while to see if that kid could go home. I had a patient who lives in Tama County, playing basketball, fell and broke his hand and is going to see Dr. Close. I'm here Tuesday. We splinted that fracture, and he'll see Dr. Close for follow-up and reevaluation of that injury. And then we probably had 2 or 3 psychiatric patients, people who are either strung out on meth and drugs and they're just not able to make good decisions for themselves, or they're depressed and thinking about suicide. So we'll get them to a place where they're safe and then help get them plugged into resources to treat that illness.
The question was, how do you stay calm? You deal with a variety of situations. How do you stay calm in a very extreme situation?
I think, you're not thrown right into that with your training. So I remember when I was a first-year resident, one of my senior residents, we were in the ER, and somebody's heart went out of rhythm, and basically had a sudden death event. And my third-year resident had seen this 10 times. This was my first time. So he just said, well, come on, under my wing, and we'll go take care of this guy. And I was basically the shadow at the bedside. And he, you see the thing on the ER where they put gel on the paddles and shock them, and that's what they did with that guy. So when you're in your first year, you're not usually solely responsible for anything. In fact, you're just smart enough to be dangerous. And so you have a lot of support, a lot of oversight. And you slowly, over time, are put into those experiences where you're more and more responsible. It was like Dr. Close said, when he was in his first year of residency, they just let him suture. They didn't even let him cut on anything. They didn't let him set any bones, you know, until the end of his first year. Then maybe you get 1 or 2 cases with some strong oversight. And so you're never just expected to be able to navigate that kind of stress right away. Some of you will naturally be able to handle certain kinds of cases more than others, and that may be why you gravitate to a certain field. You know, Callie may really be rewarded when she interacts with infants, but may really just not find much reward interacting with sick elderly people. And other folks may be exactly the opposite. Some people may just detest hearing a kid cry or have pain when they have to put, you know, an IV in a little baby, but they're fine with that on an 80-year-old. And we need doctors and care providers in all these fields, so none of these is right or wrong, but it allows you to kind of play your strength.
Orthopedic.
I drive my wife crazy, something breaks in the house and she wants to throw it away or buy a new one. I'm like, whoa, I haven't had a chance to fix it yet. Orthopedics is kind of that. The human body wants to heal itself, and so sometimes I got to stay out of the way of the human body, letting it heal itself. But there's a lot of times what I like the idea of there is something wrong that I can fix. And not necessarily like the bone is still going to be broken, but I can make it set it better and make it get a better function outcome. And I did not like the idea of treating chronic medical things where, so like you can't cure diabetes, you treat diabetes, and that seemed very frustrating to me. So I like the idea of definitely impacting a patient's life through treating a problem.
So the question was, how often do their positions overlap and maybe hand off to a colleague? Obviously, we saw some of that interaction.
So in my daily office, not at all, but when I'm on call, quite a bit. So just like he mentioned, if there's a broken bone, like I wasn't even aware of that today, but he said, hey, I'm going to send it to your office, and that patient will show up on Monday or Tuesday, and I'll have a note from him, and so this is what we did.
For me, I switch. I'm on call 1 week, and then the other provider's on call the other week. So we just give a report on our patients at the end of the week. So, but it's probably a good question for you.
So every shift, when you come on, it's pretty uncommon that the previous doctor who was on has all their work wrapped up. So on shift, you'll inherit anywhere from 1 to 4 patients from the previous physician, and then finish up that workup. Maybe it's somebody who came in with chest pain and they're waiting on some labs and an X-ray to be completed, and then we can make a decision about what's causing their chest pain. But probably 5 times in 12 hours, I'll have to call a specialist physician, like one of these two, to come in and help manage a sick baby, or if I had a bad car accident with a bad knee or ankle injury and I need Dr. Close's help, I'll call him in. And so in the ER, my job is more of half of it's treatment, and the other half is just figuring out what the heck is going on and who do I get, who do I involve to come recruit to the table to help solve this problem. So that's an everyday issue for me.
I mean, we heard in terms of your training and the number of years, that can be probably intimidating to some. I'm going to go undergraduate, and I've got medical school, and I've got residency. That can be intimidating, perhaps for the length of time, but also the finance, or how, in terms of getting through medical school. Any advice or recommendations you would give these students that are thinking of pursuing this as a provider for sustaining, getting through that time, and maybe even the finances side of it?
I would just give yourselves the permission to imagine being in training that long. If you get into any career, even if you go right out of high school or college and go into the job market, you're going to start at the bottom and slowly work your way up. You're not going to get the high-income job right away. And I don't really look at medical school and residency as any different. Yes, in med school you're paying for your training, but you just have to trust me when I tell you that it is it's demanding, but it also is rewarding. Every year there's something new. You're sort of making yourself better. You're learning new things. You're honing your craft, and there's something kind of fun about that. Instead of just doing the same grind, the same job Monday through Friday. I'll let these two talk more since they're a little closer to the schooling.
I would just say that you can still have a life. I moved several times. I got married. I've had 2 kids. I've had 2 different jobs. Well, I mean, they're both nursing, but I lived in Kansas, moved back to Iowa. You can still have a life. Also, as far as financial, I mean, I ended up using student loans for the most part for a lot of my education. But I would say, like, definitely take advantage of grants, apply for scholarships, take the time to apply for scholarships. There's a lot of scholarships out there, and then if you can work part-time or PRN or anything and contribute anything to try to pay interest on your loans. But chances are, if you're in school, a lot of them are not in repayment, but it does help to pay down on the interest.
Yeah, I use student loans myself. I got a lot of heavy debt right now, and I'm just starting to pay that off. But I had friends that there's some military opportunities, and so the military academy, not the academy, excuse me, the military branches will pay for your medical school if you apply. You just have a commitment at the end, and then you're debt free. So there's definitely options. There's scholarships out there. You can do whatever you want. I'm kind of like her. I had a couple kids before med school, and then I had my third one in med school, and so I'm a little non-traditional. Got a high schooler, Marshalltown high school freshman. So a little bit older, but I just finished.
Okay. Round of applause for Dr. Lance.
Thank you so very much. We appreciate your time on the podium. There's a card for each and every one of you, so appreciate the time you took today. All right, you guys, we are going to our first morning breakout session. So on your name tags, it will either say Unity Point Health or UPH or IVVCCD. Those who are going to Unity Point Health, I'm going to have you guys go with Christine. She's waving in the back. It should be right after your high school, your grade, and then it will say UPH. If you are UPH, Christine is in the back, and you will be hopping on a bus going to Unity Point Health across the street.
So what we kind of have planned for you this morning is you'll do some just little stations in here where you can listen to people's hearts and lungs and bowels and learn a little bit about what we do for nursing, kind of with each one of those systems. And then we have MediMan on over here, so you can see how he blinks. You can look at his pupil reaction. He actually has pulses. He's kind of groovy. His chest actually goes up and down. I know, aren't you so excited? I'm so excited too. So, and then when we're done here, so we'll spend about 20 or 25 minutes here, I think. And then you'll have a chance to take a break. And then in the other room, you're going to learn about diabetics and administer some insulin to our mannequins over there. So you'll use the nursing or the physician's orders to administer some insulin for some blood sugars over there, okay? So what we have is, you're gonna divide into 4 groups, and I can't already remember what number did I say, 14? So you should be in groups of like 3 or 4, okay? It doesn't matter how, and you can just go to one of the stations. These are our nursing students. They'll introduce themselves. You'll spend about 5 minutes there, and then we'll keep switching. So you don't have to make the commitment of what system you like, because you're going to do all of them, okay? You're welcome to touch things. You're going to use the stethoscopes. There's a surprise with the cardiac station. So you could ask questions. The students are happy to answer any that you have. And so it's hands-on, enjoy yourself, because otherwise we're going to fall asleep because it's really early in the morning, isn't it?
Really early in the morning.
Is everybody feeling early in the morning? I'm like, whoa, it's early. So just divide up and find your stations, and we'll get going, okay?
We would go ahead and administer oxygen. So I have the nasal cannula hooked up, but otherwise you can hook it up to like a non-rebreather to help them breathe. But if they get claustrophobic, you don't want to put that on.
If you don't have pulses in your feet, you don't. Isn't it crazy?
She moved the leg and I got scared.
He does not walk. It's fine. But these are really important for circulation. Okay, so everybody find a pulse and feel it, and then I want you to tell me what happens when I change something. Okay. Tell me about how your pulses feel now.
Can't feel it.
Stronger or weaker? His blood pressure right now is 46/36. Do you want to know what a normal blood pressure is?
Ooh.
Isn't it like around?
She knows it, I think. I remember I took what's it called?
Yeah.
Medical last year. Oh.
It's okay. Top number, usually around 120. Bottom number, usually around 80. Your top number is the pressure when your heart squeezes. Your bottom number is the pressure on your vessels when the heart relaxes. Now tell me, keep feeling your pulse because I got something new for you. You ready? What do you want to guess the blood pressure is now? High, right? I have him set at 212 over 154. But about 130 is the highest I've ever taken. Beyond that, the vessels, what do you think happens if it gets too high? Exactly. I made that hand motion, didn't I? I almost answered your question for you. They break. And so do you know what happens? The vessel actually ruptures. And so what would happen? What's in the vessel? Blood, and it goes out. Okay? So that's a stroke. The vessels in our brain are very fragile. So when the pressure gets too much, the blood can actually leak out, and that's a stroke. Do you guys know some things that cause high blood pressure? I can tell you that diabetes, okay, because the kidneys don't work as well, okay, so that causes high blood pressure. If you have high cholesterol, plaque kind of fills in on the side of the vessel, so then the blood can't get through there as easily. Anything, nicotine, that's why when people smoke, it's a vasoconstrictor, and so your vessels are about this big, and that blood's trying to get through there, and it creates a lot of pressure. Because this is fascinating. Let's get closer. Okay? So Amber, did you tell them why they need a tube down their nose?
Okay, go ahead.
If we get bored. If nurses get bored, we just put a tube down your nose. No, that'd be weird. Okay, do you see how it's going down? Isn't that fascinating? Oh, will it not go all the way? It's supposed to come all the way to the stomach.
It has.
Did it go down last time?
I've never seen even Kathy get down that far.
Oh yeah, it does. It goes. There we go.
Oh, wow.
Yay! Is that not cool? Yeah. So that's what an NG tube is. That's what it does. Only one works at a time, so you twist it.
I don't think you get it any further.
That's a nursing student trick, because they're like, the other side doesn't work, you have to turn it.
And you have it.
Yeah.
Can you imagine like how it
Yep,
feels?
if you see a cardiologist, they always use this side. Because there's higher...
You see how easy it would be to just continue to go up?
Oh, good, you're placing an NG tube. Excellent job. If it won't go all the way down, it's because this. If you need to, just tip it back a little bit. Now try it.
Is it too hot? Is it too tall for you?
Yeah, you can just.
I know what it's like to be short.
Oh yeah.
Trust me.
All right, everybody got a pulse? So we have an
Oh my God, baby's actually getting away. Yeah, look at you. Yeah, you did it. You got it all the way in there.
Yep, right here. Put your hands together. Yep. You're gonna go right here. And you're gonna push hard. So since these side rails are up, you can always, if you need to climb on the bed to get near your patient, but you're gonna push deep and hard on this patient.
Does it matter which hand is over the other?
Whatever you're comfortable with. Yep. It's usually gonna be your dominant hand on top, because you're gonna apply pressure. So your dominant hand is always stronger. So it usually would be your, whatever hand you write with is your dominant hand. And you're gonna push down. But you can imagine how much it's gonna hurt when you wake up from having a heart attack and being shocked.
Why do we let go when shocked?
You wanna stand clear because you don't wanna absorb any of that shock that's coming off this machine. We want all that shock to go to our patient having a heart attack.
Wait, so even if you're touching a person, that still
You
goes
could,
to you?
no, I mean if you're near like the pads, then it could possibly shock you, but I mean if you're touching his hand, you're fine, but you want to be back and you want to make sure everybody around you, usually if this happens in a public place, there's going to be a ton of people around, so you want to tell everybody stand back, and the machine will keep prompting you for your next step, so it'll say stand clear, and you just yell at everybody, stand back, so.